Okay, so hello and welcome to this short talk on Haematology and Immunology. I'm a human biology student, and as part of an investigative team, I'm investigating some blood findings and some biomarker findings for this particular patient which we're diagnosing as part of this university assessment which we have to do. This isn't what I'm actually doing for my assessment. I should note this is a separate talk to that. This is to provide some students of human biology potentially in the future with the tools necessary in order to help diagnose and investigate how to go about investigating a patient who you present and you're given this evidence such as blood findings of various different types and how you'd actually go about this diagnosis. So first of all, our patient has a few haematological findings, which is this blood inspection findings, which were revealed by these blood counts. And a blood film was provided, these blood counts were taken, and it revealed Basophilia, or we actually investigated these down a microscope and revealed Basophilia, Eosinophilia and Monocytosis, which in case you're not familiar with these terms, Basophilia increase in basophil numbers above the healthy range, Eosinophilia increase in eosinophils above the healthy range, and monocytosis increase in monocytes above the healthy range. So first of all, monocytosis, we looked at the common causes of this from a developmental country in terms of this research paper which was published in that country, and we identified 5 major sources of this monocytosis which potentially could explain the patient's monocytosis, and these were malaria, dengue hemorrhagic fever, diabetes, acute viral infections and tuberculosis. So firstly, we deemed it unlikely that this patient would have malaria and dengue hemorrhagic fever, as these typically are more commonly prevalent in tropical areas, and we had no evidence that our patient had travelled to these areas, suggesting that these explanations for monocytosis were unlikely. So then we looked at tuberculosis, and again tuberculosis seemed unlikely, as there's only 6,000 cases diagnosed per year within the UK, and only 10% of these are symptomatic, and our patients had some of these symptoms resembling that of TB, so it'd have to be one of 600, which obviously is 10% of 6,000. It'd have to be one of those 600 people in order to explain this monocytosis with tuberculosis findings. So follow-up sputum smear would be necessary in order to fully eliminate that. However, it is considered a hugely unlikely condition to explain his monocytosis. So we continued our investigations and investigated some other sources of potential monocytosis, and we looked at diabetes, as I've said. And diabetes, our patient presented with thirst, and this is a common finding in diabetes, which I believe is due to osmolarity of the blood, this glucose increasing that. I need further follow-up reading to confirm that for you. However, he presents with many risk factors for this diabetes also. He presents with stress, he presents with alcohol consumption on a fairly regular basis, not excessive certainly, but alcohol is still a risk factor for it. Smoking and aging. This patient's 52, he's not very young, and it's likely that he's going to sort of begin to possess some of these more common aging features as he progresses in age. So in order to confirm the absence or presence of diabetes, we would need a follow-up glucose urine test. In addition to all these risk factors and thirst, it puts together a particularly convincing argument that he actually has diabetes. We highly expect this to be type 2 diabetes, not type 1, because type 2 diabetes explains 90% of the diabetes within Western countries, and type 1 diabetes, where your own immune system attacks your islets of Langerhans, this is likely to have been diagnosed in his case history, and there was no evidence that this has been previously diagnosed, suggesting a more kind of late onset, if you like, diabetes, such as type 2, which has emerged recently, and 90% of the cases in the UK and other Western countries are type 2, suggesting that this is highly likely. So, whilst obviously not confirmed, we do these glucose urine tests in order to confirm this. It is suggested that he may well have this. So moving on to acute viral infections, another potential cause, another one of the 2 most likely causes, I should add, for monocytosis. We investigated common cold. This typically does not lead to monocytosis, so this was deemed unlikely. However, acute types of hepatitis were investigated, such as hepatitis A and hepatitis E. Hepatitis A was considered unlikely in our patient due to his blood findings. He was not presenting with lymphocytosis that would be expected if he had this hepatitis A, suggesting that it could only be hepatitis E if it was an acute form of viral hepatitis. So we investigated the risk of hepatitis E, and because there was absence of travel history to places such as Africa or India, this was also deemed unlikely. So we had to look further afield. We looked at other types of hepatitis which were non-viral but could still explain this monocytosis blood finding. We actually investigated alcoholic hepatitis, which can explain monocytosis still. It was deemed unlikely that he would have chronic alcoholic hepatitis because his anemia was too mild, which means reduction in red blood cell count was too mild to indicate this chronic alcoholic hepatitis, suggesting it was far more likely he had a more acute form of alcoholic hepatitis. So, with that in mind, acute alcoholic hepatitis, he would still need to be drinking significantly more than he's actually saying, but patients do underestimate drinking. Our patient supposedly drinks a few glasses of beer per week. However, what he actually drinks, we don't actually know, suggesting that he may well be underestimating these findings to make himself sound healthier than he is, in which case a follow-up in order to confirm the absence or presence of acute alcoholic hepatitis would be necessary. These typically would be tests such as aminotransferase assays, in addition to liver biopsy. Aminotransferase shouldn't be used in isolation, but should be used in conjunction with this liver biopsy test in order to confirm the absence or presence of this alcoholic hepatitis. And what would typically be seen then on this aminotransferase assay? Well, typically, if the ratio of aspartate to alanine aminotransferase is equal to or greater than 2 to 1, this is strongly indicative that he has acute alcoholic hepatitis, or alcoholic hepatitis in general, but acute because of his milder anemia. But liver biopsy may well help to confirm this and is typically needed to be used in conjunction with this test. So moving on, other causes, or essentially causes of other findings, I should say, such as eosinophilia and basophilia, should now be discussed. So he presents with eosinophilia, 9,606 eosinophils per microliter of his blood, and this is far more marked, this is far more severe than would be expected in a patient who just has rhinitis, allergic or non-allergic rhinitis, as these typically will present with below 1,500 eosinophils per microliter of blood, suggesting more likely to be a more sinister cause, a more severe cause, such as a myeloproliferative disorder, such as a leukemia type, for example. It's also unlikely that he has a parasitic infection to explain this eosinophilia, because again these are typically present predominantly in the tropics, and we have no evidence that he's travelled to the tropics, suggesting that this is unlikely. Exploring basophilia to be on the safe side also, we can see that rarely skin diseases are causes of basophilia. However, far more commonly conditions again such as these allergic conditions such as allergic rhinitis, more commonly known as hay fever by the way, would be an explanation for basophilia more typically. However, our patient possesses far too marked eosinophil elevation to be indicative of that as a cause of basophilia, suggesting an alternative cause may well be present, such as these types of leukemia. So we investigated various types of leukemia and found that by far in the Western world the most common type of leukemia was chronic lymphoid leukemia, rather than more acute forms which were slightly rarer, but also our patient does not present with bone pain and lymph node swelling, which would be indicative of acute types of leukemia, suggesting that he does have a more chronic form of leukemia. Chronic lymphoid leukemia, as I've just said, is by far the most common, suggesting we'd expect him to have this. However, he does present with monocytosis, which typically would not be seen in chronic lymphoid leukemia, suggesting an alternative type. And the only alternative type really which we noticed with these types of hematological findings was chronic myeloid leukemia, as this presents with basophilia, eosinophilia and monocytosis. However, follow-up again would be necessary in order to confirm the presence of chronic myeloid leukemia, and these typically would be follow-up tests such as bone marrow biopsy follow-up tests, or other follow-up tests for leukemia, such as blood cell morphology inspection, which should obviously reveal aberrant blood cell morphology. This morphology should be abnormal in theory if leukemia is present. Okay, so that's our hematology findings. So it may be good to actually summarise what we've just said. So diabetes type 2, we've said is quite likely, although it needs this follow-up glucose test. Liver abnormalities caused by this acute alcoholic hepatitis may will need follow-up tests in order to confirm the presence of this, such as liver biopsy. ALP function tests are useful for assessing the function of the liver, and aminotransferase tests for that. In addition to that, obviously chronic myeloid leukemia, we also need to investigate bone marrow biopsy, blood cell morphology inspection. So these are the major findings and conditions which ideally need these follow-up tests. So moving on to immunology. One of the most effective biomarkers for immunology is CEA, in addition to VEGF, and greater amounts of this CEA, carcinoembryonic antigen in full, is indicative of poorer prognosis, which means a likelihood of poorer outcome for our patient, and therefore more long-lasting, severe, or more kind of sinister damage than would be expected with a lower level of CEA. Our patient's CEA are elevated, indicative of a number of different conditions. It's not 100% specific to CEA, despite being one of the most effective biomarkers, as it can indicate hepatitis, which, as we said, our patient may have acute alcoholic hepatitis. Lung cancer, colon cancer, or irritable bowel disease are all some conditions which may be indicated by this CEA biomarker. However, a biopsy was performed before this immunology section of my presentation, essentially of our clinical diagnosis, and this revealed biopsy findings consistent with colon cancer, suggesting that he's likely to have this, not these other causes, potential causes of CEA elevation, suggesting that we do kind of know what this is likely to be as a result of, which is the colon cancer. However, using this biomarker as an indicator of the effectiveness of our patient's recovery is not ideal, because if you did have, for argument's sake, hepatitis in addition to this colon cancer, this may well interfere with these CEA readings and cause artificial elevations in these readings, which may interfere with the assessment of how effectively our patient is recovering. So, with that in mind, what do we know about our patient's cancer? Well, this CEA is particularly effective at assessing this. The CEA relapse, our patient 12 weeks, I should say, after his operation, had this CEA assessment from his blood serum again, where this was measured, and his surgery actually helped rectify these issues in CEA and reduced CEA levels, indicating recovery. However, they didn't completely reduce, and they returned 12 weeks post-operation, suggesting that his cancer had returned from somewhere. Potentially, the surgeon may not have removed 100% of the cancer from the colon. However, it may well have been that there's been some lymph node infiltration and the cancer has returned to the colon from the lymphatic system, suggesting that the cancer may well have come back from sites such as the lymphatic system, and suggesting that this cancer has invaded the lymphatics, which cancer can spread to other areas through the lymphatic system. It's worth noting that not just the lymphatic system, it may well spread through the blood, but our patient, due to CEA relapse in levels, is strongly indicative that this has in fact invaded the lymphatic system. The CEA time frame of this relapse within 2 years is more strongly indicative of liver rather than lung metastasis, which for colon cancer are the two major sites of metastasis from the colon, so the liver and the lung, and within 2 years, as I've said, strongly indicative of liver metastasis. In terms of clinical biochemical tests which were performed before this immunology as well, these revealed ALP elevation, which is indicative of liver function issues, suggesting again that it may well have metastasized to the liver rather than the lungs. However, our patient also presents with persistent cough, suggesting that he may well be presenting with indicators of lung metastasis. So follow-up scans such as CTs or MRIs are definitely required in order to confirm the absence of this lung metastasis. So, in summary, overall, our patient is likely to have this, well, in fact does have colon cancer, which is highly likely to have gone metastatic to the liver. However, we're awaiting confirmation due to the absence or presence of lung cancer from the CT or MRI scan. In addition to this, type 2 diabetes supporting evidence was revealed from this glucose urine test. This was found to be positive. This came back, suggesting that he does actually have diabetes, in addition to thirst, and his risk factors strongly indicative of type 2 diabetes. So our patient presents with type 2 diabetes and colon cancer which have gone metastatic. In terms of treatment for this then, metastatic colon cancer, radiotherapy in addition to chemotherapy are particularly effective treatments for metastatic cancer. Various types of chemotherapy may be implemented, such as cisplatin or methotrexate, drugs such as this. In terms of his diabetes, he may well want diabetes follow-up treatment, but the management for this cancer and diabetes can be performed just by managing his risk factors for this, or his lifestyle factors I should say, some of which are risk factors admittedly, such as smoking. He should reduce his alcohol consumption, and since he has a poor diet, which he volunteered in the diagnostic appointment, this is suggested to be a contributive factor for diabetes, as fatty food, any food with just high glycemic index, sugary fatty foods are typical contributors to the condition of diabetes, suggesting that he should try and reduce this consumption of fatty and sugary food. So thanks for listening. Hope this diagnosis has been helpful for your own research investigations if you're a student, or has just been interesting if you're just interested in hearing about the work of a human biology student and these investigations which we carry out as part of a diagnostic team in terms of this exciting module. Well, I feel it's quite exciting that we're doing. So if you have any further questions, please leave them in the comments of this video. I'll try and get back to you, or any queries or issues of what I've said, please get back to me and I'll do my best to kind of rectify them in the comments section. If not, thank you very much for listening, and I really hope you'll view some of my videos in future. Thanks for listening, and this has been Human Biology Student. Goodbye.